Does anybody have any residual comments or questions based on the thyroid lecture? Everybody ready to go through the unknowns? Woo! All right. I'm gonna do like I did last time because that was fun. And I'm gonna make one of you come up and drive the slide, even just like to describe it. Even if you can't come up with a differential, that's fine. But at this point, you should at least be able to come up with like maybe some kind of vague thought. So come on down. Come on, Priscilla, come on, you're on head and neck, you get it. So you're gonna do case one, and I didn't give you histories because, like, I don't know, it's a thyroid nodule in a person. And besides that, like, not too much for this unknown set matters, so go for it.
Alright, so just for low power, it's there's macro follicles and micro. And it looks like it's well sort of trapped. So I see a kind of a capsule around it. Some lymphoid aggregates surrounding.
So in one word, what would you call those lymphoid aggregates in thyroid parenchyma? Thyroiditis. All right, good.
And then being a papillary architecture this way, but so I do see some rippling and some chromatin clearing. Some overlapping nuclei. Yes. So I guess right now, so far, top of my differential will be PTC.
No invasion.
So far, not in the best. I don't see this part.
Right.
So
All right, so we have a, thank you. So we have a circumscribed lesion that maybe has a focal capsule that does not show invasion, but it has some like papillary-like architecture and some worrisome nuclear features. So just show of hands, who is ready to go on and call this PTC? Who is not ready to go on and call this PTC? Okay, good. What additional information do you want, or what other features in this might help you make a decision one way or the other? Anybody? Mutation. So what kind of mutation would you be looking for? So BRAF V600E or NTRK fusion for conventional PTC. And what about non-PTC? RAS or RAS-like. Okay. So if you have that information from molecular testing, that could be helpful. But there are some other features here that I want to point out that I think are maybe worthwhile discussing. So we're going to talk about the molecular in a second, which you're right, BRAF-like versus RAS-like. And so this is a problem, I think, in a lot of follicular pattern thyroid neoplasms in terms of if you're thinking about PTC, but there's no invasion, and you have 100% follicles, then you're thinking what? NIFP, right? If you are thinking PTC and there's no invasion and you have PTC nuclei, but you have what look like maybe papillae, then technically you're like not on an NIFP program anymore, right? Because you are questionably dealing with papillae. But we have to ask ourselves, like, what's going on here? Are these papillae worth considering to be real papillae, or are there these sort of geographic infoldings, right, with some follicles in the stroma. And so this is a really, really, really tough problem in thyroid pathology, right? And so if you look at some of these areas, you'll say, oh wow, that's a really thin branching core with like a thin vessel in the middle, and that really could be a true papillum. So how do you account for these papillae versus not papillae? Question mark. I'm not sure yet. The other thing is, what's also missing from here when we think about classic PTCs? Usually classic PTCs have pretty decent, dense, and abundant eosinophilic cytoplasm, which this kind of doesn't. The cytoplasm that's there is kind of vague. It's kind of pale. The other thing that we haven't seen yet are true pseudo-inclusions. So this is one of those cases that may be on this border between, if I think these are real papillae, this could be PTC. If I don't, are we dealing with some kind of like architecturally atypical, like quote unquote NIFT-P? And it's these kind of structures that to me, like, maybe aren't really papillae, right? Because you have follicles in the core, right? You have follicles in the core, which isn't really by definition, you know, a true papillum. And so this, I'm starting you off the bat with probably one of the most controversial questions, because I think you will go out into practice, and if you are signing out thyroid, you will encounter this and you will want to know how to deal with this. This has RAS. Okay, so this is a RAS mutated tumor. So if you throw your BRAF V600E stain on here and it's negative, you are like 80% chance of this being correctly not a PTC, right? But if you have the knowledge of the molecular from the FNA, and this is RAS-like, then I would be very cautious about calling something RAS-like a papillary carcinoma in the absence of invasion, right? Because we know biologically those are different. What we do, regardless of whether you end up calling this a circumscribed PTC or a weird RAS-like tumor, what do you think the patient's going to behave like? Are they going to metastasize to nodes? No. Are they going to metastasize to visceral sites? No, because there's no angio invasion. What's going to happen to them? Probably nothing, right? So the point to come across is in the absence of intrathyroidal invasion, in the absence of angio invasion, right? They're probably not going to be non-metastatic, and they are probably going to be observable, right? So your point to the clinical team would be observation is okay, regardless of what name you put on it, because you're going to get PTC over here, you're going to get NIFT-P over here, and you're going to get benign over here, right? So I'm asking you mostly to think critically about how you want to communicate to the clinical team on how to treat the patient, more so than what exact name you're going to pin on it, because you may or may not have molecular information in practicality, right? But the bottom line is these are good behaving tumors. The second example is really similar, and it's a different patient, but the concept is the same. It's a circumscribed lesion. There's maybe partially a capsule. There's partially a little like blip into, but certainly not 100% through the capsule, right? So we can't really consider this full thickness capsular invasion. And then when we look at the morphology of the inside, you have combined both follicles and now this growth pattern. And how would you describe this growth pattern? Trabecular, exactly, right? So they're sort of elongated. They don't have colloid in the middle, and there are these elongated things called trabeculae. So same concept here. Regardless of what the inside necessarily looks like, if the outside doesn't show invasion and you are dealing with a microfollicular to trabecular architecture with variable nuclei, I would argue this is also an indolent behavior. And this is another example of a RAS driven, not a BRAF driven. Okay? Am I making sense? You guys have questions? Okay. Case 2, who's coming up? Thank you. So as you come up, this is an example of a circumscribed follicular patterned neoplasm that on gross examination, you may have wanted to cut the poles of the nodule, right, perpendicularly, so that you're able to see the interface between tumor and capsule, and this is a good example of that grossing pattern. And as Dane will show you, maybe you can see why it's an important section to take.
Yeah, so definitely encapsulated. Hard to say. It's this is
Mm-hmm.
kind of nested.
Mm-hmm. Maybe go on a little bit lower power. So I think best thyroid is best really started on low power. So even here, go one lower. Do you see this shape that this thing is
Oh,
taking?
right here.
Yeah.
So this would probably be broken
Yeah.
through.
Mm-hmm.
Uh,
Probably not as easy to say on this one, yeah?
yeah.
Yeah. Okay, so with the capsule, maybe with some breaking through the capsule, with some follicular and nested architecture, how are the nuclei looking? Are they really worrisome to you, or are they not so worrisome?
I would say not super worrisome.
Yeah. I mean, there's some clearing here and there. Yes, there will generally be clearing, but a lot of them are round, right? A lot of them don't have significant elongation or grooving, but many of them do have some clearing. So, you know, it is what it is. And the second slide is the same patient. Now, what did you think about that area that you sort of doubled back on? Yeah.
I was just wondering about this.
Yeah.
They almost look a little distinct. Let's look at the sites.
So I think those are probably just crushed follicular epithelial cells that sometimes end up looking like lymphocytes. So if do you think what's on the left side of the capsule is the same as what's on the right side? Probably. So cancer or not cancer?
Probably cancer.
Probably cancer because of what we perceive as probable capsular invasion, and we'll go over that in a second. What kind of cancer? How are you gonna name it?
Something follicular.
Something follicular. Follicular what? Exactly. See, this is not even a question. Follicular thyroid carcinoma. Okay, come on down. All right, thank you. So I think the point of this being, unlike the first case, right, where you really have a very clean border, in this case, you don't, right? And so for me, examination of invasion on thyroid is often best done at a very, very low magnification, where if you can't draw a nice clean line around the thing, that's, okay, fine if it goes a little bit like this, but if it's like, woo, right? If you're on a roller coaster ride with this line, that's cancer, right? And so we see why this perpendicular sectioning of the poles of the nodule can be very helpful, because you can identify invasion in a pole, right? And so if you were to not have done the sectioning this way, and you were to just have cut it like this probably would have been a lot harder, because you would have been looking at the capsule like this, right, rather than like this. So just kind of conceptually why that sectioning is important. You can see these three sections how in one there's nothing, right? In one there's no invasion. In the next, you probably actually have what might be perceived of as a mushroom, right, with a stalk and a cap. And then in the third, you essentially lose the stalk, right? And you just have the cap outside the capsule. So these are all the various manifestations of what you might end up seeing in what is potentially follicular thyroid carcinoma with invasion. And so I try not to get lost in the weeds of like what's going on in the hemorrhage, but more like what does this overall look like? And so we have invasion in a follicular carcinoma, and over here we also have, again, the cap, but without the stalk. And if you believe that this is the same as this, then you're money. And I think morphologically we can imagine that these are all pretty morphologically similar. And so you might again get into the weeds in terms of, all right, what kind of clearing is this? What kind of wrinkling is this? Well, all of these follicular epithelial cells have relatively round nuclei. And yes, there are some wrinkles, yes, there are some grooves, but arguably the morphologic features are not very robust for papillary, and the growth pattern is completely follicular, with the exception of, again, some of these like hyperplastic looking like projections, right, proliferations into the lumina. So again, if you were to throw BRAF V600E on this would be negative, because this is another one of these RAS-driven tumors that just happens to have some wonky looking clearing. So follicular thyroid carcinoma. Once you see follicular thyroid carcinoma, what do you then have to ask yourself? Angioinvasive or not, because that's gonna potentially buy the patient completion thyroidectomy with radioactive iodine, whereas capsular invasion only might not. Next question. Solid areas and mitoses and or what goes with mitosis? Necrosis, right? So you always then have to ask yourself, could it be worse, right? So is there angioinvasion? In this case, there wasn't. Is there mitoses, necrosis with solid growth? No. So we're not pushing it up into the high-grade cancer. It's just going to remain at a capsular invasion. So this would be minimally invasive follicular thyroid carcinoma, minimally invasive being capsular invasion only, not angioinvasion. Okay? Okay. Yes. Come on down. Case 3.
So on low power culture process, plasmaplasia.
Good.
Capsule. I just keep double clicking stomach.
Or you can use the scroller in and out as well.
This is cytologic. Considered
Clearing, yep. I think that's just a vessel.
and then so it's the angioinvasion.
No, I think that you're literally cutting through the wall of a muscular vessel. I don't think that's a tumor. Yeah. So if you go to these larger nests of tumor, yeah, what is the growth pattern? Is it solid? Is it papillary? Is it follicular?
It's solid.
And what else are you seeing in the solid nests? That pink stuff at the bottom of the screen. Now it's at the right,
Oh,
it's off the screen. What in your right, yeah, that's,
That's right.
yeah, mhm. Yeah, right, you kind of see ghosts, right, you see ghosts of nuclei in there, and it's in the center of an otherwise viable tumor nest, right, so now you have necrosis, okay, cool. So you have an infiltrative process with necrosis. So regardless of what final tag you put on it, where are we already now? Are we at a well-differentiated carcinoma or a anaplastic carcinoma or a high-grade carcinoma? High-grade carcinoma, right? If you think about thyroid, and thank you. If you think about thyroid in three segments, right? Essentially, follicular cell-derived tumors, right? Well-differentiated carcinoma, anaplastic carcinoma on the two ends of the spectrum, and high-grade in between. And the minute you see true tumor necrosis, you're at least at high-grade carcinoma, right? You're at least at high-grade carcinoma. And then we have to decide what kind of high-grade carcinoma is this? Okay, do you think this is morphologically ugly enough to be anaplastic? No, right? You can still make out good epithelioid structure, you can still make out good kind of structures, little maybe abortive papillae. So no, we're not at anaplastic yet. So we're at high grade. Do you think this is a papillary style process or a follicular style process? Papillary, why?
nuclei system. You have some clearing, you have some grooves, and
Mhm.
I think they even found a couple rare pseudo inclusions.
Cool.
Here, there's actual.
And our friends, Simoma bodies, right? So it's an overall architectural pattern of a very highly infiltrative thing with, as mentioned, a lot of sort of background desmoplasia, right? So that already kind of clues you into the overall morphology of the way that papillary invades in this very desmoplastic thing, right? If you look around, you can certainly find better differentiated areas with good papillae with fibrovascular cores, right? And with Simoma bodies, which we know are pretty much exclusively PTC. If you don't decalcify these, which is fine, you don't have to decalcify them, but when they get cut in the microtome, they chunk out. But often you'll still see the little concentric lamellated sort of bits right at the edge. So this would be a concentrically lamellated Simomatous ring. And everywhere you see these little punctate foci of necrosis. So when you start seeing these very brightly eosinophilic things on low power, right, go check them out because chances are they could be necrosis. So you have a high-grade papillary carcinoma, check. Now at the periphery, what's happening out here?
Going into the muscle.
Say that again?
It's going into the muscle.
It's going into the skeletal muscle. So you have a high-grade thyroid carcinoma. You favor it to be papillary, so that's high grade, right? Now you have skeletal muscle invasion. What else does that make this? High, not grade, but I know we haven't talked about this yet. Stage, right? So grade is what you see on how bad the tumor looks. Stage is how far out has it gone. And so for thyroid, stage into skeletal muscle bumps it higher, right? So we always want to be sure if we see skeletal muscle at the periphery, that we note whether it's involved or uninvolved by carcinoma, and we correlate with the operative report because they will often mention that there was some adherence or stickiness, and usually that means clinically they think it might have invaded the muscle. Because normally in thyroid, they do not take any strap muscle. So already, if you see grossly, sometimes strap muscle can sort of mimic colloid because it's all brown and it can be hard to tell. But as we gross thyroids, maybe you can practice seeing muscle. If you see skeletal muscle, always sample it because it generally shouldn't be there. And if they have taken this amount of skeletal muscle, that often means they think there's something invading it, right? So that's already a soft sign to there being extrathyroidal extension. The difference with strap muscle is if you are in the isthmus, and I think we mentioned this in the didactic, right? If you're in the isthmus, the thyroid normally travels up and down the midline, so you can get trickling of normal thyroid in the skeletal muscle, but only in the isthmic area, right? If you're out in the lateral lobes, you cannot. Okay, so just be cautious of where you are. If we assume this was inked correctly, we're at blue, right? So we're at a lateral lobe, right? We're not at the isthmus. So just keep in mind that. Make sense? Okay, who's next? Thank you.
Right, so first thing I see is this kind of looks like well circumscribed, big, very pale pink nodule in kind of a periphery, sort of looks like just normal thyroid. Up closer, you can almost tell even at this lower power, this is just all dead, it's all necrotic. And then there looks like some viable something along the edges, and again, we sort of have almost like sort of desmoplastic fibrous capsular areas encapsulating it. Higher there's a lot of inflammatory debris, maybe some apoptotic debris, and then like these like pinkish globular looking things around it. Just from looking at some of the maybe more viable nuclei, they didn't look like PTC, they're a little bit darker, but I couldn't quite place them as anything. But with this amount of necrosis, even though it's sort of encapsulated, I'm thinking this is something malignant, especially with the amount of necrosis. And with these, they kind of like amyloidy. So I was kind of thinking, is this medullary? I don't think I've ever actually seen one.
Okay.
But
okay.
but it
Cool.
could also just be, I guess, dying.
Yeah.
It could just be like
Yeah.
necrotic
Yeah.
fans looking at what this
Yeah.
looks like.
Yeah, yeah,
So I was kind of wondering, is this something that was treated before it was taken out? Or is this completely wrong, different?
Yeah.
But the amount of like inflammation
Uh-huh.
makes me
Yeah.
think it might have been treated, and especially how weird these guys.
What do you think those cells at the edge are that are viable?
I don't know. Maybe I mean they didn't look super neuroendocrine to me, but they don't look like they're forming like the epithelium that you can see in PTC.
Yeah.
So maybe it's follicular. I don't know. That's just big.
Big nucleus, right?
Big nucleus, yes.
Big nucleus, and then what are these things? Are those follicular epithelial cells or something else? With the kind of grungy cytoplasm?
Yeah, I don't know. You know, if I wasn't in the thyroid, well, I kind of was like, oh, it's still here with macrophage. It's not the architecture of it, but maybe if you have like macrophages, it's so foamy.
Yeah, it's really foamy, right? And there's this like yellowish material in some of them. So yeah, I think a lot of those are histiocytes.
Okay.
And there may or may not be some residual follicular epithelial cells at the periphery that are compressed that you were kind of pointing out with those big nuclei. But I think a lot of the viable periphery is histiocytes. Yeah. Okay. All right. Cool. Thank you. Last question. Is it invasive?
Yeah. At low power, I didn't really see it, but I was looking at some of this,
Mhm.
and I just thought it was like hard to tell. There
Yeah.
was some like vessels where I'm like, I don't know what this is going on.
Yeah.
So it's tough because I think there's some like reactive,
Yes. There's a lot of
Stroma,
reactive stuff happening.
but
Yeah.
possibly it wasn't super clear to me though.
Wasn't super clear. Okay, thank you. So, who 100% knows what's going on here? Ischemia. So, one, you have basically complete death of whatever is happening here with ghosted outlines of follicles, right? So these are probably the residual cells, with questionable viable cells at the periphery, which some of them may or may not be actual epithelial cells, and many of them are probably histiocytes. But there is a relatively intact-ish capsule with a lot of sort of desmoplasia and some fibrosis and some histiocytes like we saw, and maybe even some, I thought I saw some hematoidin, yeah, this like really, really bright yellow stuff. So what happened to this nodule? FNA happened to this nodule. What was the underlying cell population in this nodule? What can you infer? Follicular cells, and specifically, just based on the architecture of the death, and what specific type of follicular cells? So yes, probably microfollicular. What? Hurthal, so oncocytic. So this is a huge pitfall or problem, specifically in oncocytic adenomatous nodules. They are highly sensitive to FNA. And so there have been patient reports of like a week or whatever, a few days after FNA, they experience like severe pain in their neck. And sometimes they end up getting resected and it's dead. It's completely infarcted. And so this is specific to oncocytic morphology. I don't know why. I don't know, they must be somehow very sensitive to like focal damage, and then they release some kind of cytokine and the whole nodule dies. I don't even know. But so this, sometimes if you're lucky, you can see a peripheral rim of oncocytes. We maybe these are a few here that you were kind of pointing out with these large nuclei with prominent nucleoli. There's a cell border there. So you probably have a few oncocytes, and if you wanted, you could throw a keratin or a Pax8 on there to see. Although the Pax8 is going to pick up your lymphocytes, so just be careful. Maybe a keratin or a TTF1 would be better in the context of inflammation. But these are probably some residual viable cells. And as long as you don't see any oncocytic anything outside of the capsule, you can probably safely assume that this probably was benign, but it can be really, really, really hard to say. So sometimes I just call these infarcted, follicular neoplasm. See comment. Like I see a capsule, I don't see any definitive invasion, but it's all dead. So maybe it probably was an oncocytic adenoma. But specifically, this happens with oncocytic things. You can get partial infarction, so like half of it is dead, and usually, again, the viable is going to be at the periphery. So submit the periphery and see if you can see any viable, okay? Okay. Who's next? Come on. Is this cancer or not cancer?
Cancer.
Looks like cancer. Wonderful. Practice your growth skills.
Here we can see like remnant thyroid tissue.
Mm-hmm.
Well, the rest is tumor and it's like multifocal. Or
Yeah.
It's not well circumscribed.
Yes, wonderful. So this is what thyroid cancer, grossly 100% will look like. Very white, kind of multinodular. Yeah, okay, cool.
You can see, well, again, these multinodular features, and you can see here how it's infiltrating normal parenchyma.
Mhm.
Like here.
Yeah.
It looks very cool on low power.
Yeah.
So on higher power, that's that is making follicles.
Mm-hmm.
This nuclei doesn't look like PTC nuclei, and I think it's in this one. Here we have some small ovaries.
Yeah. Mm-hmm.
Saw these before, and I think I saw an area with necrosis that I'm not finding now.
Yeah, you
So that
probably
might-
did.
Maybe okay, this is at least high grade,
Mm-hmm.
it's not anaplastic.
Yeah.
So I would say that it's high grade.
Mhm.
And, high grade,
And do you want to put it more in a papillary bucket or more in a follicular bucket?
since we have small ovaries. Up here.
Papillary. But you mentioned that the nuclei aren't so bad, right?
Yeah, no, so I thought some of my bodies were pretty specific.
Samoma bodies are pretty specific. So when you see this morphology where you have a highly infiltrative tumor, right? This is highly infiltrated. You have Samomatous calcifications, but your nuclei aren't super PTC-like. Overall, what might you want to think about? Do you think this is going to be a BRAF-like tumor? Do you think this is going to be a RAS-like tumor, or do you think this is going to be something else? You vote RAS. So if you vote RAS, then we can't really call it PTC, can we?
No.
What about you, Andrew? What else? What's something else?
Of the entity, not the mutation.
What?
Of the entity, not the mutation.
Ah, what entity are you thinking? Ah, you're thinking medullary. Okay, so could be a medullary pattern, although arguably this medullary tends to be more solid without these overt like follicular or papillary structures. Oh, it's the Grostrom's that are frozen. Hey, it's Nicole. Hi. Oh, okay. What is it? Okay. Oh, okay. All right. I'm finishing up a lecture with the residents, but I'll head over. Okay, thanks. Bye. Yeah, so there's probably too much architecture here for this to be medullary, meaning too many follicles, maybe even some papillae. I'm not sure. Can I grab this from you? Thank you. Thank you. So you pointed out a few good key features that we have to think about. So the Samoma bodies, absolutely, those are real Samomatous calcifications. If you were to want to prove the origin of these cells, they're not medullary, or they're calcitonin negative, they're TTF1 PAX8 fibroglobulin positive. Also, they don't have the sort of kind of elongated neuroendocrine like chromatin of medullary, okay? But this is neither a BRAF nor a RAS, okay? This is that borderline. This is the NTRK fusion carcinoma, okay? So when you see features that don't really make 100% certain sense, think about NTRK, and this may matter clinically because they might want to treat with an NTRK inhibitor. So you have a highly infiltrative sclerosing growth pattern, like you think about with papillary. You have Samoma bodies like you have papillary, but you have a very follicular pattern, kind of nested growth pattern without overtly PTC-like nuclei. Think about this NTRK tumor, and that's what this is. This is ETV6 NTRK3, okay? So this is that one that I told you on that chart. It like straddles the line, right? It straddles the line between BRAF and NRAS, and the morphology mirrors that with hybrid features. Okay, unfortunately, there's a Posner frozen. How do you want to handle this? Do you want me to quickly go over these last cases? Do you want me to do 20 to 30 minutes, like at some other point in the day today? What do you want me to do? Just go through them? Okay. Who knows what the next tumor is? Hyalinizing trabecular tumor, right? So it's very circumscribed. It's got very rich stroma. It's got some like maybe pseudofollicular spaces, but mostly it is these sort of trabecular cords, right? With they're in there somewhere. There's true intranuclear cytoplasmic pseudoocclusion. So study this on your own. This is in fact a hyalinizing trabecular tumor with these sort of very, very elongated trabeculae with elongated nuclei. There's maybe one and a pseudoocclusion. So this is the PAX Bliss fusion tumor. 7. What? Tall cell. Is it very pink? Yes. Is the cytoplasm very pink? No, the cytoplasm is very pale, right?
Columnar cell.
This
That's
is,
okay.
this is columnar cell with the cytoplasmic vacuoles, right? So if you didn't know this was thyroid, I don't know, I might look at this and be like, I don't know, is this like endometrial carcinoma, right? It's very blue, it's got these elongated nuclei with sub or supranuclear vacuoles right here, right? It's not densely eosinophilic. The next one is tall cell. These have these very elongated follicles with really dense eosinophilic cytoplasm. So compare and contrast. So 7 is a columnar cell, 8 is a tall cell. And tall cell is gonna be BRAF V600E positive, columnar cell usually not, okay? And then the last one, yeah, what does it look like? If I didn't tell you this was thyroid or thyroid area, what does it look like? Squamous cell carcinoma, right? So when you are dealing with a thyroid or a thyroid invading trachea, which is what this is, and it looks squamous, this is probably squamous anaplastic. So this is not a laryngotracheal, they even, look, here's tracheal cartilage. This is not a tracheal SCC. So correlate with imaging, right? If this is at all associated with thyroid, or there's a thyroid mass and it could be diving backwards into the trachea and it looks squamous, this is anaplastic thyroid carcinoma. It is in fact, this is BRAF. It was one of the weaker ones, but it's BRAF positive. This was biopsied from farther out in the neck. So look at these, but you'll convince yourself that this is a conventional papillary carcinoma, which is also BRAF positive, right? So this arises from a PTC. You can see the resection specimen here that has both squamoid and papillary, conventional architecture, and you can see they had to do a partial tracheal resection. So the point here being squamous, 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 anaplastic, 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 BRAF, BRAF, BRAF. Okay. And then the very, 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 very last one, which is like super juicy and hemorrhagic. But kind of interesting in as much as it also lacks that overt papillary nuclear morphology, right? But it has some kind of follicles, or how might you describe this architecture? What? Organoid with punched out holes in it. So when it's organoid with punched out holes, that means somebody said it. Cribriform? Cribriform, right? So that is cribriform morphology. I know it's not very robust here, but in areas like this, right, that's cribriform morphology, these back-to-back glands with punched out spaces. So you have cribriform morphology. You also have some areas of papillae with these elongated nuclei. So this kind of looks it almost resembles, interestingly enough, I don't know, to me it almost resembles like the NTRK fusion case where it has this, like it's very similar, but it has that particular very cribriform morphology. So when you see that, what does that make you want to think of? What subtype? Cribriform morular thyroid carcinoma. So this is PAX8 in the background thyroid. This is PAX8 in the tumor. Remember we talked about how cribriform morular is no longer a variant of PTC because it's PAX8 negative and we don't know where it comes from. And this is beta-catenin. And I know it's really, really, really strong, but oh dear God. If you look carefully in places, you can see nuclear expression, and it's not a very clean stain. But normally beta-catenin is only in the membrane, and now it looks like it's covering and it's moving into the cytoplasm, and in some cells it's moving into the nucleus. And so you can see here the nucleus looks very dark, right? So this patient should be worked up for FAP if they don't already have it. So when you, again, weird morphology, think about the weird variants, think about the NTRK fusion, think about, in this case, cribriform morular. So hopefully that was all helpful. Okay, sorry to cut it short. Thank
Thank you.
you.
Got one. Yeah.